I tried to choose a title. Are we really talking about a foe, an enemy, or we are overrating or overestimating the issue of the biochemical failure amongst patients with prostate cancer? So we need to learn from what we know about prostate cancer. This publication in 2021 addressing meta-analysis of Italian material of patients for about 20 years treatment, the outcome of treating prostate cancer patients over 20 years, and it incorporated over 460,000 patients. This is really a big number. And what we learned from this, that it's an ultimately fatal disease, that over the period of treating cancer prostate for 15 years, fatality is ultimate. Definitely, not only because of the disease, but also because of the age-related comorbidities, as we are treating usually elderly patients. And the second piece of information, that the metastatic fatality also is inevitable. If you have a patient with prostate cancer and he experienced metastatic disease, fatality will be the end of the story 100%. What about the earlier phases of the disease? I mean the localized disease, but not really the localized only, the localized with state of biochemical failure following control of the disease effectively for a while, either surgically or following non-surgical approach as radiation and hormonal treatment. Look to this. Still we have significant proportion of our patients with biochemical failure. They are going to develop metastatic disease, and once we are in the metastatic phase of the disease, it means that fatality is inevitable for patient with metastatic prostate cancer. So we are talking about a continuously upstaging disease. This is very important piece of information that we need to keep in our back mind while tailoring a treatment strategy for patients with prostate cancer. And metastatic disease is fatal, and also biochemical failure, significant proportions are going to develop metastatic disease across their natural history. So we need to keep the patient for the longest ever duration while in the biochemical failure phase, or the controlled biochemical failure, before developing metastasis. So we started to have a terminology of the metastasis-free survival. As an oncologist, all of us are fanatics with the overall survival. Anybody treating cancer, we are talking about the overall survival. But when we can talk about this among certain diseases, but for diseases like the prostate cancer, we do expect to have a protracted survival. To reach the firm conclusion about the overall survival advantage, it might take a very long time, and you are preventing effective therapies from being approved, waiting for the overall survival. And because of this, we started to realize that we should have other endpoints to realize the value of adding therapeutics. Of them, the metastasis-free survival. When we look to the patients with biochemical failure disease, through this also publication in 2024, analyzing more than 22,000 patients for about 10 years duration, they found that patients who are going to face the biochemical failure state, the metastasis-free survival at 5 and 10 years, they are 80 and 60%, which means that you are going to lose about 40% of your patients who faced the state of biochemical failure, because they are going to develop metastasis at 10 years. And 20% of them will pass directly to the castrate-resistant prostate cancer. It means that biochemical failure state, once you have a biochemical failure, you need to do all the possible ways to keep your patient without developing metastasis. In other words, to keep him localized, not metastatic. And the metastasis-free survival, again, we are all fanatics with the overall survival. So, can we consider the metastasis-free survival to be a surrogate endpoint for overall survival? So, we can tell that if we are going to extend the metastasis-free survival to a significant duration, more than what we have already, this will be reflected on the overall survival. Again, this publication addressing analysis of 15,000 patients amongst 14 randomized trials, and it was stated clearly that there is a strong statistical correlation between the metastasis-free survival and overall survival. So, MFS or metastasis-free survival could be a primary endpoint to validate the use of certain therapeutics about just prolonging this duration over the available therapeutics. So, should we focus on all patients and treat all patients with biochemical failure to reach the metastasis-free survival prolongation or not? Or are trying to identify certain patients who are really in need to be treated more aggressively than what we do? When we look to the disease progression amongst patients with localized disease, either following prostatectomy or following radiation and hormonal treatment, you will find that still significant proportion of patients are going to have biochemical failure at 15 years duration of follow-up. Of them, those classified as high-risk patients, those with high T, those with lymph nodes, those with extracapsular extension, those with lymph nodes affection, they are all categorized as high risk, in addition to patients with high PSA kinetics, in addition to the Gleason grouping. So, patients localized, not metastatic, started to be treated with local measures, either surgical or non-surgical approaches, and they are classified as high risk from the start. They are more likely to develop biochemical failure, as you see. Following prostatectomy, 46% are going to develop metastasis after having the, they are going to show biochemical failure after diagnosis, and most of the relapses or the progression will occur within the first 3 years following the initial treatment, while for patients receiving radiation and hormonal treatment, less number of patients are going to show the biochemical failure, which means that those patients are systemic disease, are having systemic disease from the start. And because of this, the local measures only, I mean surgery, will not offer them the value of being free of biochemical failure and the progression to the metastatic phase, as opposed to the radiation and the hormonal treatment, because hormonal treatment, ADT, is a systemic treatment, so it will deal with the micrometastatic disease, which is expected to be more pronounced with high risk patients. So this is the first one. Patients with high risk disease are those who we should focus on to prevent the progression from biochemical failure to metastatic disease. Second, PSA is a gold standard for diagnosis and monitoring of patients with prostate cancer, and more specifically the PSA doubling time. If it's more than 9 months, as you see in the left sided table within the green square, it is not significant. It means that PSA doubling time more than 9 months be somewhat quiet. Still, you are not facing the situation that biochemical failure is inevitable. And when we go down below 9 months, here what we have, a significant correlation with the metastasis-free survival. So if you have a patient with biochemical failure and the PSA doubling time is below 9 months, take care. This patient is going to flare very soon and it needs your immediate intervention. Again, another validation of what we have, that other trial published recently in 2025, that PSA doubling time below 12 months is not only correlated with the metastasis-free survival, it's correlated with the overall survival. So, to keep your patient without PSA progression, with PSA doubling time below more than 12 months, it means that you are going to face longer overall survival, and it attracts your attention to the need to treat those patients and the following identification of them. A lot of us, when we treat patients with localized prostate cancer and we started to have PSA progression, we are somewhat skeptical about starting treatment. So to go for the immediate treatment or to go for delayed intervention, definitely you can notice the separation between the curves, favoring the immediate interaction in terms of overall survival, and to keep your patient away from the complications of disease progression of prostate cancer. Again, early intervention is better. Another way to calculate it in a financial perspective. If you are going to have a patient with localized prostate cancer, whether he's going to be treated in or outpatient basis, it's definitely more cheaper and more economic than treating a patient with metastatic disease in or outpatient basis. So we need to keep again our patient in a state of metastasis free. We need to interfere as early as possible once we have the first alarming sign about the biochemical failure, to be without metastasis for the longest possible duration. And this is another point, that we need to focus on the biochemical failure to identify the patients who are more likely to develop metastasis at any point. This is the contemporary management of the biochemical failure over time. After radical prostatectomy, you should expect that the PSA should be lower than 0.2 nanogram and even 0 if the operation is well performed and eradicating all the disease there. And here we can go for radiation, hormonal, or a combination of both, or hormonal treatment only if we don't have the way to irradiate. And for patients with following radiation therapy, again we can go for salvage radical prostatectomy, although it's quite hard to do prostatectomy for patient irradiated for radical dose. To go for brachytherapy or HIFU, still it's there in the guidelines, but we don't have much information about this. Or to go for just ADT to control your patient. But are you satisfied with the outcome? I think, as we are going to see, the answer is no. Based on what we have, that we have a state of biochemical failure, we identified patients with high risk factors, started for the first time to be treated with the IMPARC trial for patients with biochemical failure following locoregional management and having high risk features as PSA doubling time below 9 months. And we have seen why we have chosen the 9 months as a cut-off point, as well for the higher Gleason grouping, to be randomized between 3 arms: the conventional treatment, to go for just ADT, or to go for ADT plus enzalutamide, which is one of the androgen receptor signaling inhibitors, very potent ones, or enzalutamide alone. And this was the first impressive result for the metastasis-free survival extension for the combined arm, I mean enzalutamide plus the ADT. At 5 years, we have 87.3 versus 71.4% as a metastasis-free survival with strong hazard ratio. The hazard ratio was quite impressive for those patients, 0.42. 0.42 hazard ratio, it's statistically, it's quite significant and amazing. And for the secondary endpoints as the overall survival, because we consider the MFS or the metastasis-free survival to be a surrogate endpoint for the overall survival, it was significantly better for doing the combined approach, as well as freedom from PSA progression and the time for the first use of other antineoplastic drugs, which is a valid endpoint among patients with prostate cancer. For the enzalutamide monotherapy, it was superior to the ADT alone again, and it was 80% versus 71.4 in the as a 5-year rate, with a hazard ratio of 0.63. Still, you can save your patient from being heavily treated with the ADT plus enzalutamide. You can go for enzalutamide monotherapy amongst well-selected patients, and still you will have significant prolongation of the metastasis-free survival, as well for the other endpoints, the secondary endpoints, the overall survival, PSA progression, and first time for use of other antineoplastic treatment. For the overall survival as an endpoint, we are talking, don't forget that we are talking about a long protracted history of disease and the survival extended. So to have 0.78 hazard ratio favoring the use of enzalutamide plus ADT over ADT alone, again, it's quite impressive results. And what's really important, that for how long you are going to have undetectable BSA as a critical measure, the gold standard for following up patients with prostate cancer. You can achieve this significant endpoint to have a controlled BSA in about 90% of patients with ADT plus ENZA, and 85% for monotherapy. But for the ADT alone, you are going to lose about 1/3 of your patients, because they are going to have metastasis-free survival outcome compromised as compared to the ENZA plus ADT and the ENZA alone. And for the first time, you can suspend your treatment, saving your patient from the adverse events of the hormonal blockade. For the combined arm, it's about 20 months you can suspend your treatment before initiation of treatment again. For the adverse events, no new safety warnings, and the 3 arms were more or less equivalent to each other, although somewhat pronounced but insignificantly for the combined arm. What about the patient had received radiation therapy previously? And this is a classic management for biochemical failure following prostatectomy, for example. Here, the benefit of adding ENZA combination was pronounced with a hazard ratio of 0.45. You spared about 55% of your patients from dying due to disease progression. And also for monotherapy following radiation therapy and the state of biochemical failure, 0.57, you spared about 43% of your patients from dying due to progressive disease. We started with ENZA, and we have data coming from phase 2 for the other androgen receptor signaling inhibitors. For the abiraterone acetate in the CLARA phase 2 trial, using abiraterone acetate prednisone plus radiation therapy, the biochemical relapse-free survival was 81% at 2 years. This is very good. But still we need to have data coming from phase 3. Also for the abalutamide in the ABA-RB following radical prostatectomy or radiation therapy, the biochemical relapse-free survival at 24 months, it was 100%. It means that abalutamide was quite effective in preventing the state of biochemical failure, but still also we need to have data from phase 3. I do believe that it's coming very soon. For the darolutamide, the other anti-androgen, this is a study design for the ARA-STEP in a similar fashion for patients with high-risk biochemical failure. This is a study design, but yet now we don't have data for the outcome. So my take-home message that the biochemical failure, it represents a significant risk following glucoregional curative treatment, and based on the stratification, which is quite essential to define which patient who is going to receive treatment aiming at prevention or prolongation of the metastasis-free survival, which serves as a real surrogate endpoint for the overall survival. Definitely data from EMBARK posed a new chapter in the story of the management of prostate cancer, and we do expect it to have the more prolongation, more significant prolongation of survival upon having more chapters and having a specific treatment for every chapter, ensuring exposure to the all available therapeutics across the platform. And definitely in the future we need to have some biological validation for what we have, simply for eradication of the circulating tumor cells following treatment for the biochemical failure rate, reflecting the effectiveness of the selected treatment in keeping your patient without progression to the metastatic phase. And again, thank you very much for your kind attention.